Good afternoon, everybody. It is Wednesday, the 23rd of December. We're now in the winter phase of the seasons, and this is the last Lunch and Learn until after the first of the year. Today we have Dr. Turner, Robert Turner, goes by Rusty. He's going to be talking to us about some of the research in terms of how COVID impacts the brain. He has sent us a few articles, and what I will do towards the end of the presentation is I will forward those out on the listserv so you all have them. If he's going to give us these slides, he'll shoot those to me at the end, and I'll put those up as well. This is going to be recorded, so we are not going to let people ask questions and answers, and we'll give Rusty about a 10-minute heads up, about 10 to the hour. So without any further of my talking, Rusty, thanks again for coming back so soon.
And
Love having you
also,
here. Richard, go ahead.
yeah, Rusty, could you click on the little icon at the bottom? Yeah, right there, so that we get more screen, because people who are watching, that's easier for them to see. Great. Now we can all.
Right now you see both, right? Let me
Yeah.
switch it. There we go.
There we go. Perfect. All right.
Now that's great. And I also like to mention one of the reasons it's so important to have Rusty talking is he's a neurologist and we aren't.
That's right.
All
right. Thanks, Rusty.
Thank you. Sometimes I wonder if I'm a neurologist too, but good afternoon or good morning or good evening, wherever everybody is. I didn't intend to make a PowerPoint with some slides, but looking at these articles proved to be a huge learning and exploratory process for me. And there's certainly no lack of articles about COVID-19 and everything in the universe being affected by that at this point. So I still throw this in every PowerPoint. I don't have any financial disclosures, commercial interest. I am COVID negative also. I didn't put that there just for the time being. So the paper of discussion you may have already reviewed. It's called a systematic review of EEG findings in 617 patients diagnosed with COVID. So I hope to get through that, throw in some editorial comments and give an overview of what the authors have done, and then a few other articles that I would love to highlight because I've come away with more questions after doing this review and the work. And then hopefully we'll have time for some questions and maybe even a question I might be able to answer, but that might be doubtable. So basically the slides are busy, but hopefully if you want to go back through them, I'll try to summarize what we see. And we know this, I love the way they worded it, this pandemic continues to test the resilience of healthcare systems and the limits of our understanding of viral infections of the nervous system. There's obviously been an interest in EEG. It's being done a lot. EEGs aren't just being ordered routinely for people unless they have symptoms. So this is obviously a heavily biased study because they're doing EEGs in people that are symptomatic with COVID of all types of symptoms, but particularly affecting the brain, encephalitis, encephalopathy. We know there has been a report of lots of complications neurologically. There's a lot of selection bias with that, so it's also generated a lot of untold fear associated with it, but we need to just hopefully maintain a healthy sense of common sense during this time. Many studies, so they took a bunch of these studies that have been published talking about EEG information and trying to basically, not a meta-analysis, but synthesize it, put it all together. And they said here, individuals study stress specific population demographics. That's kind of obvious. There's some aspect of the EEG, but they don't together. There's a huge mosaic of findings. And there's many groups, children to elderly, from asymptomatic patients, and there's very few papers with EEG in asymptomatic patients. but that's a whole nother discussion about QEEG to be able to detect findings before they show up, as well as the very ill individuals with COVID. Some of the studies have noted a preponderance of frontal findings putatively linked to the mode of entry of the virus into the brain. So when I bold things or italicize things, those are changes that I've made as I've made these slides. Big thing here in summary, and this is the conclusion from their paper, which you really don't gather when you read the abstract and other things, is there is no common EEG pattern that has evolved unique or pathognomonic or diagnostic for COVID-19. And I think as we discuss that, that will make sense. So they reviewed a bunch of papers and a cumulative amount of individuals that had had EEGs related to having COVID encephalopathy. Again, encephalopathy, just something's going wrong with the brain. The common findings in all these studies: diffuse slowing, periodic patterns we'll talk about, and then seizure or possible seizures or status. And one thing that we don't have as a comparison is if we did this same thing with all ICU patients, apart from those diagnosed with COVID. These are also the most common findings in EEGs in the ICU: diffuse slowing, periodic patterns, seizures, and status. And there was a very good paper some years ago on the amount of undiagnosed subclinical status epilepticus, people actually having subclinical seizures in the ICU, because we don't typically monitor the brain. You get in the ICU, you get the EKG thing strapped on, they monitor respiration, but who's monitoring the brain? But I'm getting off on my high horse there. So frontal EEG findings, in their opinion, supports a putative viral entry of olfactory mucosa. EEG changes could be from systemic causes or due to direct brain involvement. And I don't know how well I'll answer that, or they've answered that in this paper, and I think the verdict is still out. This is the summary, the abstract, too detailed, that's in the paper that will be made available. All these are in the public domain, so the papers I'll refer to today are really good reading. As they broke it down, they had a total number of 617 EEG individuals with seizures. Where gender was reported, they had a predominance of twice as many men as women. Average age is getting very close to home at 61.3 years, since I'm well past that at this point. There were 4 pediatric patients reported. How they got this data was mostly with so-called routine EEG, or a short, brief 20-minute, 1-hour EEG. What they concluded in our systematic review: continuous EEG studies reported significantly more abnormalities compared to routine EEG, suggesting higher sensitivity of prolonged recording. That's kind of that's pretty obvious. The longer you look at the sky, you're going to see a lot more different kinds of clouds. So still valuable information. And then many centers have a very rapid hookup that the residents can often do to a limited EEG, and they had a few in that population as well. The number one complaint: altered mental status. Things ain't right, brain is off. That's what happens when we get sick. And that's by far the majority. And then seizure-like events they described as eye deviation, altered mental status as far as level of consciousness, anything that might be suspicious for a seizure. That was the second highest reason for obtaining an EEG. The others: speech issues, cardiac arrest, still there, but obviously much more obvious indication for getting an EEG. I refer, as a side note here in this very busy slide, they did report findings from 2 studies with QEEG analysis were included. I thought that was good of them to do that. I think, why don't we do quantitative analysis on all EEGs? It gives us so much more information, but here we are. And they quoted 2 papers, one in the clinical neurophysiology, where they did a single center study looking at the QEEG features, and they did it after sedation is withdrawn. sedation is a big issue. Many of the patients in these studies are sick and many of them are getting sedation. So there's a lot of sedation effects that is a confounding factor in interpreting studies like this. So QEEG features at baseline and reactivity can prognosticate neurological recovery in critically ill patients with COVID-19. Could you imagine how much more information we could be using clinically if we were doing the QEEG, especially early on? Most of the EEGs that were done that resulted in this cumulative study were done an average of about 10 days, somewhere 7 to 14 days after onset of hospitalization. So again, as they got sicker, they got the EEGs. This other paper published in Journal of Clinical Medicine, used QEEG to define features of encephalopathy. We all know how valuable quantitative assessment of the EEG is to give us clinical information about brain function. Their conclusion in this paper was that visual inspection of the EEG, when we look at the squiggles, showed a near physiological pattern with scarce anomalies. In their opinion and their experience of their patients that they were reporting, EEG abnormalities were not very common. And that tends to be the experience of a lot of medical centers. That kind of stuff isn't going to typically get published. So we have the publication bias. We're going to publish what's abnormal, what's getting all the attention, and particularly in the sicker individuals. They also said specifically the temporal lobe showed a different distribution for EEG bands in COVID patients. Hemispheric connectivity was also lower. Those things shouldn't surprise us, I think. In my understanding, if you have a sick brain or an ill functioning nervous system, it doesn't connect as well. So the interesting thing about the temporal lobes, as opposed to the frontal lobe bias in this publication, or the frontal lobe report in this publication. And so they did this, they reported it. It was a small number of individuals, but it's still, as in most papers, more studies are needed. We need to check whether COVID patients not admitted to the ICU, but with cognitive complaints, share the same EEG pattern. And I think we're all hearing about that daily in the media, in all the papers that Rob keeps sending and reporting. More and more of this cognitive, long-term cognitive issue is happening. And a couple of the other papers I reviewed left me with more questions. So I want to get, before we get to the question and answer time, I want to throw out my concerns, my questions, and my confusion on what preparing for this has resulted in, non-COVID related confusion. So they did a whole huge database, and I think in here, I didn't break it down, but whole internet search that eventually resulted in a number of papers that they could, were reasons they excluded certain papers. And anyway, came down with this summary of the papers that they reviewed, a total of 84. And then that resulted in the 617 individuals. The tables are pretty well done. The background abnormalities is mostly the slowing. That's the blue bar, up to 70%. And I have the numbers here, 68.6%, and that's in the paper. But that's by far the slowest. Again, that shouldn't surprise us. If somebody's pretty sick and their bodies are sick, their brains are often affected too. So COVID-induced encephalopathy. Focal slowing, and I'll talk a little more about that, as will show in those percentages, about half, a little less than half, seem to be more focal in the frontal region. So but my question in understanding the proportion of the frontal cortex to the entire cortex is about 35 to 40%. So in some ways that shouldn't significantly surprise us, but that's just my opinion. So I'm interested in discussion that if this is a much larger area over the frontal, we're going to find more abnormalities in the frontal compared to temporal, parietal, occipital localization. Periodic and rhythmic patterns. Generalized PD stands for paroxysmal discharges RD is repetitive discharges, and I'll talk about SERPIDs in just a little bit. One thing I've noticed over the years in neurology, when we can't invent anything new, we just invent a whole bunch of new acronyms that I then have to remember and write down and teach. So paroxysmal discharges basically means there's something apart from the baseline that isn't necessarily a seizure or an epileptiform abnormality, but it's just an interruption in the EEG. And these are many different types. The other type is they're mostly generalized, not focal, or multifocal. So they really didn't have and a pure focal characterization. These multifocal means it can occur anywhere through the brain. Again, the whole brain's affected. The question that we're looking at is the frontal lobe more involved, and perhaps is that because of a oropharyngeal or nasal route of entry for the virus? SERPIDs I have here, acronym stimulus-induced rhythmic, periodic, or ictal discharges. I guess SERPID sounds kind of cool. Basically, any type of stimulation, tactile, somatosensory, auditory, visual, can produce a change in the EEG. That's going to be much more reported and discussed in patients that are in coma or some significant degree of encephalopathy. Epileptiform abnormalities, basically spikes. On here, they put ED unknown in this small bar here, epileptiform discharges. They meant unspecified or unclassified. They couldn't really tell if it was focal, multifocal, or generalized. And then we'll talk about the numbers of patients in this case report collection that had actual seizures. Excuse me. Here's the numbers that go with the pictures. Again, diffuse slowing, that's the big thing. That's also the biggest finding in any ICU study of critically ill patients. Same thing with the discharges. So again, nothing, unfortunately, is coming out as tremendously unique thus far, except possibly the frontal focus. And we'll certainly know a lot more about this in a year from now. Diffuse background slowing, the most common, indicating, as they put in the paper, a diffuse non-specific encephalopathy, and that's the most common. And that would make sense, as it would with any illness, infectious or metabolic illness going on. Other features suggest diffuse encephalopathy with generalized rhythmic slowing, the delta activity, generalized periodic discharges. They have one slide that I'll show with some of those images. Generally, this is not something you're going to see in outpatient clinical practice, but the whole thing about detecting and recording EEG is what do we look for early on? And what if our clients or our patients are complaining of certain symptoms? So when they had multifocal abnormalities, it suggested coexistent focal dysfunction in some patients. Again, that shouldn't I don't think that should surprise us. When you have an illness affecting the brain in a generalized fashion, there are going to be local areas that are more susceptible to problems. Spike or epileptiform discharges were common, 13%, indicating underlying cortical irritability predisposing to seizures. You've heard those terms that we as neurologists or epileptologists use. Just cortical irritability does not imply the diagnosis of epilepsy. And again, in an illness situation like this, you're not going to be diagnosing somebody with epilepsy because they're sick and having seizures. So those are illness-provoked seizures. 5.5% had seizures or resulted in status epilepticus. And again, looking at an ICU population apart from COVID, this is not that unusual. So here's the tables. Frontal EEG findings were about half, 52 of their numbers versus 105 for all those regions. And you can see in the status over here on the right, 10 out of 20, these were focal status that seemed to originate from the frontal region versus other areas where the seizures came from. So again, the history of CNS pathology. This is another critical thing. History of CNS pathology was reported in 43% of patients with the interictal epileptiform discharges, that's what IED stands for, compared to 9% in those without IEDs. Again, what I've heard, and I am not an expert by any means on COVID or the world pandemic, but what I've heard is that many people who are getting sick or have had worse outcomes or worse course of the illness have already at least 1 or 2 or 3 comorbid diagnoses and illnesses. And I hope we'll get to in a few minutes, one of the biggest comorbidities I think that we are ignoring is the pandemic of sleep dysfunction. And I'll show you where we'll go with that in just a little bit. So definitely focality, more frontal. All right, that's weird. I didn't know I had emergency alerts on. That was not a COVID alert. Okay, my apology. Even got me going. So that's the epileptiform discharges here, and it doesn't show up as well because this was all one slide and I did not take one each individual and blow it up. But these are the focal and some frontal findings that they described. A here, if it shows up relatively well, shows kind of a periodic, they call it generalized rhythmic delta. It occurs on both sides of the brain. It is a little more frontal temporal, but that's the generalized, they call them biphasic. There's this downturn and the upturn delta activity. So that's one.
Rusty, can I just say, so it's kind of an intermittent delta wave that just comes periodically, right?
Yes, yeah. Yes, so slow, again, delta 0 to 4 hertz, 1 to 4 hertz. So slow, and again, delta or FERDA, and that term really wasn't used. FERDA, frontal intermittent rhythmic delta activity, is probably one of the most common findings in ICU encephalopathy, period. The frontal lobes are more susceptible for various reasons, I think. And that's in all the textbooks and all the atlases. So that in itself isn't unusual, at least in my opinion. So that's A. Does that help answer the question?
Yes, that was great. I was just trying to help clarify for everybody who's not as.
Yeah, please do speak up when I'm not clear with it. More GERDAs. I like the term GERDA, but anyway. There's another one that's been used, not quite as much, when there's temporal intermittent rhythmic delta. That's called TERDA, but anyway, we won't go there. So frequent high amplitude biphasic delta waves in the bilateral frontal region. So here again, I guess I can enlarge it, but you see these very rhythmic. This is so rhythmic. I would question if this patient's in non-convulsive status at this point. Again, not something that you're likely to see in an outpatient clinical practice, but they had identified that as a GERDA, a little bit different than this, but this is pretty rhythmic. And I'm worried about this one too.
That seems larger and more pronounced. It's the same thing, but much bigger kind of, right?
Mm-hmm. And faster. We're at a 1 to 2 hertz frequency. So this is faster. Very rhythmic. And so I would be much more concerned about subclinical status and status epilepticus in this particular individual. Lateralized PLEDs, periodic lateralized epileptiform discharges or slowing. They show that here, predominance in the right frontal. And so again, what they did not have good information to be able to do with this is make significant MRI correlations with the amount of the subjects that they reviewed. So it'd be great if we had MRIs to show, because you would think, okay, there's a lot more going on in the right frontal region, right temporal region in this patient. What's their imaging show? Have they had a stroke? Do they have focal inflammation? D is the GERDA intermittent, low amplitude, slow, biphasic delta waves in the bilateral frontal region. So here again, more in the frontal, but pretty rhythmic. And again, myself, if I look at that, I would be concerned of when is it rhythmic from an abnormal standpoint, from an encephalopathy, when does that evolve into being subclinical seizure? And sometimes that's hard to tell, but these are the ones that they reported. The last one, intermittent, high amplitude, biphasic delta in the bilateral frontal regions. So here was right frontal, here we have it bilateral, and showing some sharp waves.
So that one in E is going up. You can see an up and down in the waves,
Yes.
whereas in C, it's just going in one direction up.
Mm-hmm. Yep, so more biphasic, again, up and down. It really, there's some thought whether there can be a triphasic pattern, which we typically think of with sort of a liver induced encephalopathy, but obviously triphasic waves can be from a lot of other reasons. So, and they took this from one of the articles that they reviewed, and that's where they took the reprint from, which they gave credit to. So frontal epileptiform discharges have been proposed as biomarkers, and they have an extensive list of articles that they reviewed. About, as we talked about, half of the reported cases of status were from the frontal regions. So I went and did my extensive Wikipedia and gross anatomy research and looked at the cubic volume of the different areas that we know the best we can of the brain. The frontal lobes, the gray matter, is 261 cubic millimeters versus 145, 252 for the temporal regions, 101 for the occipital. So again, just looking at the real estate that the frontal lobe takes, I think we're going to see a lot more in the frontal regions. In addition to the frontal lobe, they also saw involvement in the piriform cortex, limbic, thalamus, hypothalamus, brainstem, autonomic, a lot of other places. More extensive EEG findings in other patients could be due to a greater viral spread or other factors, the systemic factors that we'll talk about, pulmonary involvement, hypoxia, cardiac arrest, of course, metabolic changes. So this is sort of the caveat that a lot of these findings could be due to just they're so sick and not necessarily a maybe specific COVID biomarker. So, and these EEG changes could be due to pre-existing, really all conditions, let alone neurological diseases, because they didn't have a way to track how many of these individuals had a previous diagnosis of epilepsy. So the conclusions, make sure I'm okay on time, and then we'll move on. EEG remains a crucial tool in the management of patients with neurological manifestations of COVID, especially with encephalopathy, seizures, and status epilepticus. As for all sick patients, that was not theirs, that's mine, but that kind of makes sense. EEG is a crucial tool. QEEG is even a more crucial tool, but maybe in 2021 we'll make some headway, no pun intended, and we'll be looking even more in depth at the brain in the ICU setting. Abnormalities, when present, as we talked about, included the slowing, periodic discharges, epileptiform discharges, and seizures. They indicated the presence of localized, nonspecific encephalopathy, cortical irritability. The extent of EEG abnormalities correlates with the diagnosis of COVID, because that's what they were looking at. And what I talked about was just remembering the overall underutilization of EEG and continuous video EEG in the ICU setting. There has been an increase in COVID awareness, so there's more EEGs being ordered as well. Duration of monitoring, the longer you record, the more likely you are to see abnormalities. Pre-existing neurological conditions, they always mention epilepsy, but the comorbid systemic and other illnesses that people have are affecting the brain. We already know that. And then, of course, the severity of the disease. Some of the papers dealt with, one paper had 10 out of 17 people that died in the EEGs they recorded. They picked a very, very ill cohort that they were looking at. EEG abnormalities affecting the frontal lobe seems to be common in COVID encephalopathy and has been proposed as a potential biomarker if recorded consistently. That's their wording. And that makes sense. Again, look at the history, look at the neuroimaging, look at the science of what's coming out more with how are we getting COVID? And I'll refer to that in just a few minutes. We encourage clinical alertness to identify such findings. Thank you. Don't forget, we're healthcare providers. History, history, history. Anyway, enough said on that one. I'll get on my high horse on that too. It's been speculated that frontal EEG findings result from direct brain involvement in COVID-19, while more diffuse changes may result from either systemic involvement or more diffuse viral involvement of the brain. And that's where they leave it. So I think very helpful, interesting. Obviously, anything COVID related is on the fast track for publication. So we're going to know more. And this leaves me with questions. What about the nose? What about breathing? What about sleep? What about neurofeedback? What about whole health, which is what I'm into? And if I can spend a few minutes here, this article is one of many clinical trials to test the efficacy of melatonin in COVID-19. You probably saw the email today from Mike about the sleep-related issues and quoting Dr. Cheng's work. And so I don't have his paper up here, but this one I found also interesting. And this left me with more questions. So here's the paper. The pharmacologic, and I have a few quotes from this paper, and the the role of angiotensin converting enzyme 2 in this whole aspect of melatonin. And melatonin has significant anti-inflammatory, antioxidant, and mitochondrial protective effects. And its efficacy has been demonstrated in multiple experimental models of disease and in clinical trial in sepsis. They quoted their, I think, 2009 paper where they did the clinical trial of melatonin. I won't get into the doses because they calculate them differently, how they're used in an ICU setting. But because COVID courses with severe septic response, inflammatory issues, multiple reviews proposing melatonin as a treatment have been published. So I found this good. So from my review, maybe quick review, melatonin, I like this slide. That's not as flat as I would like to think. We like to think it is from here, but age graded. We do a lot more melatonin when we're young, when we're looking at endogenous melatonin. The older we get, down here in our 7th decade, we have less. So I'm still wondering, in our whole lifestyle, our whole society, what is the perfect storm? We obviously have tryptophan, serotonin's in that process to get to melatonin. Could it be a coincidence that we have so many serotonin reuptake inhibitors and other problems trying to address serotonin deficiencies in the brain, even though 90 or 95% of serotonin is produced in the gut? But that's another discussion. So where do we go from here? Light turns off melatonin synthesis from the sun, from the screens. And again, in a perfect storm, I'm doing a telemedicine course right now. And the whole first session was all about online presence. And if we have time, I'll show some of those slides. But the absolute astronomical life shift we've had, even in the last 10 years, especially 20 years, with what we're doing in front of screens, with the increased pervasiveness of EMF affecting all of us. We're all swimming in an incredibly different EMF soup than we were a few years ago. So this is interesting. So if we're affecting this and people don't have a healthy amount of endogenous melatonin, and that is anti-inflammatory and antioxidant and so on, are we setting up a perfect storm? This looked at the angiotensin converting enzyme 2 expressed in the airway epithelial cells, intestinal epithelial cells. So COVID-19 apparently binds to this enzyme and causes these problems. Now, airway epithelial cells are also in the nose. that we'll talk a little bit about in one of the other papers. So it can cleave, and I won't go into, but the more I talk about this, the not so smart I will sound, but there are the good angiotensins that provide protective role, including anti-atrophy, anti-fibrosis, anti-inflammation, antioxidant, and vasodilatation effects. And so it's protective. And obviously when COVID binds, it results ultimately in a release of pro-atrophy, pro-fibrosis, pro-inflammation, pro-oxidant, vasoconstrictive events. So there's no question that COVID is a devastating problem affecting people in variable degrees. So the excessive inflammatory response seems to be the major cause of death in patients. From a therapeutic, we must choose medicines that not only blunt the inflammatory response or that connection, but also combat the oxidative stress response, which aggravate the pulmonary and systemic damage. So in this paper, we want to call attention to melatonin. We know it's antioxidant, anti-inflammatory, and these may be of application against the free radicals generation and inflammation in COVID-19. As I was doing some searching, some stuff came up apparently, and I don't know if it's true, but even when President Trump was admitted, he got, I guess, the key medications, but he was also given melatonin. I don't know if that's true, but it's in the press, so who knows? Melatonin recovers lungs from oxidative damage induced by age, protecting against acute and chronic pathologies, and so on and so forth. So melatonin, particularly endogenous melatonin, is endogenous, our own naturally produced melatonin, is a good thing. So it's wise for us to ask for an intervention with melatonin administration in COVID-19. So that's kind of what they're pushing for. These last couple ones, how am I doing on time? Okay. The papers that will be available that I just kind of kept looking deeper into. How does it do what it does? Is there something different, unique about COVID? Coronavirus, besides the symptoms, may develop various neurological manifestations affecting central and peripheral nervous systems. There's also myopathic changes. How often does that occur in the ICU setting when people obviously are bedridden and may not be getting moved as frequently as they should be? So that's another confounding factor. But the manifestations can occur prior, during, or even after the onset of COVID-19. And again, we're realizing that more with COVID. We know that's been true with other viral illnesses as well, but it's just obviously a worldwide phenomenon that's getting all that attention right now. It's possible, the possible neuroimmunological mechanisms underlying the nervous system and systemic involvement and viral triggered conditions associated with COVID virus, as well as therapeutic approaches, have been considered. So what do we do with all this if it's an inflammatory response? So they look at what's the route to the nervous system, looking at going across the cribriform plate, neuronal retrograde, and I think, okay, it's in their paper, they have a little bit of the anatomy looking at that, but just otherwise pulmonary and then hematogenous dissemination, where the virus gets through the blood system and goes everywhere. There can be transportation of viruses up and down microtubules that we've known about. That's been shown with many other viruses. Olfactory nerves have a bipolar neuronal structure that connects the nasal epithelium to the CNS, to the cortex, the frontal region, inferior frontal cortex, basal ganglia, and midbrain. And these can be affected by the viruses. Contrasting evidence suggests that the SARS-CoV-2 may not directly enter the sensory neurons, but instead may target sustentacular mucosal cells, Bowman cells, or olfactory stem cells, other types of cells in the olfactory epithelium. So to date, the full pathway for nerve and glial cells infection is not convincingly explained, and I definitely did not convincingly explain that. Let's see, a few other things from this paper. So they subsequently can enter the nervous system by crossing the neural mucosal interface in the olfactory mucosa, exploiting the close vicinity to the brain. And then it appears to follow neuroanatomical structures. So it may have a particular nerve or microtubule predisposition. This paper was just a review of all the abnormalities in this particular hospital, 74 patients, and most common presentations, again, altered mental status. So again, we're biased looking at a very sick population in the hospital. Quite a few had strokes, 10 died. Disability was pretty significant among survivors for the duration. And I believe I have it somewhere else, but it was, oh, this is a problem. Hang on.
Happy to hang on. This is fascinating, Rusty.
Now I'm trying to find out where the rest of my slides are. Please hold. I guess that's it for now. But
well, we can do another part two. We're happy
yeah, no,
to. I mean,
this will be a
at this,
never-ending thing. But this
you
whole
know,
thing, sleep, and then look what we're doing. Do we have a perfect storm of a society where at least 5 billion people have electronics, if not our cell phones? What about EMF? What about this setting up melatonin, affecting our angiotensin converting enzyme, affecting our sleep? How often is that asked in a detailed fashion when people are admitted? Tell me, and we're not finding out how their sleep is. So let alone just as the more work I do, what about breathing? Good old plain nasal, diaphragmatic, mindful, restful breathing. We know all those huge benefits that are happening. So those are just some of the questions that I was left with, particularly with the sleep and the melatonin, and what are the risk factors that I hope will be addressed more and more. So go ahead, Richard. Thank you.
I was going to say in 1918, they found the medical doctors who were doing the key research on the virus found that profound rest was one of the most powerful antidotes. It's just what you're promoting here. But I just wanted to summarize real quick, stuff that for us as practitioners is obvious.
Please, go ahead.
And just starting with the serotonin melatonin thing, that would be something that we would want to make sure people were getting vitamin D and adequate melatonin. One of the things I noted is that the effect on the intestinal epithelial cells would affect, lead to an inflammatory process that would start to shut down serotonin production in the brain. Since we know that there's that bidirectional response. So having something go on with your gut alters serotonin levels and hence melatonin levels in your brain. And anybody who has an upset stomach and tries to sleep can find that out pretty quick.
Yes. Yeah.
The other thing is the virus is apparently moving through the microtubules, which is the cytoskeleton of the cell, which is in the neuron. And there's as many microtubules in the neuron as there are cells in a given brain, 10 to the 10, and that they're the seat of the changes. In other words, if you give somebody anesthesia, that is the place where the anesthesia works, within the microtubule. So if the viruses are affecting that area, it's going to also affect how drugs and anesthesia affect the brain. But also it will affect the alpha dominant frequency, because one of the key features of anesthesia is it lowers the alpha dominant frequency quickly. So that would explain some of the frontal slowing. But other than that, you've said we're going to see in these people probably some frontal delta, fairly common, some generalized slowing, and most of it will be in the front, or predominantly in the front. So we're looking at our brain maps, we're going to see a lot more alpha, particularly probably frontal and slowed alpha, and then we're going to see some more delta and theta than average, plus they're not going to be sleeping, which will make that higher than normal in the eyes open condition. So that seems like something that we would see in the QEEG that most of us as clinicians, just working from a neurofeedback perspective, would see. We wouldn't generally know about, I think a lot of us don't even know what a discharge is unless we've taken some QEEG courses on it. But you know what spikes and sharp waves are, and that seems to just be a normal part of being sick for a lot of people, but we wouldn't necessarily notice that unless we were really looking for it. So we could look for that in people who are post-COVID to see if there's enduring spikes and sharp waves. So all that sound fairly reasonable for a neurofeedback practitioner from your perspective?
Yes, yeah, thank you for doing that, yes. It's just when you see something, you're hopefully looking at your EEG that doesn't look right, that's what we're looking for. Compared to most people that come through and get their EEGs, they're going to be relatively quote unremarkable in a diagnostic standpoint. So you want the clean EEG so you can do your functional mapping.
Okay, well, I am systematically unmuting people so they can free to ask questions. And Rob may have some leading ones, or Martin, while they do it.
I was just impressed with the amount of information you're able to cover. I'm trying to get all these papers sent out. Some of them are large, folks, and I can't get them into an email. So I am now going to resend in smaller amounts and try to get most of these papers out that he's referenced. Because trying to do a Dropbox and add everybody that wants one is something I just don't have the time to do. So we'll let people ask questions as Richard gets them unmuted.
Okay.
Yeah, some of you are already unmuted if you want to jump in.
I have a comment. Dr. Turner, great presentation. Very, very good. Just, you know, one of my concerns in medicine is that how many doctors are not reading this literature and sending patients away with, well, there's nothing else we can do, and not, you know, even if they're having some difficulty with sleep and maybe some underlying some seizure issues that are kind of going on with, or maybe that since they've, you know, tested positive for COVID, no one's asking these questions, and the population is just getting sicker and sicker and sicker. My mom has just recently tested positive for COVID, and she has a lot of other underlying medical conditions. And thank goodness for my husband, who is a reader, reads, thinks, talks to other doctors who are smarter than him to help. You know, my mom hopefully will survive this. So, and literature and how you presented was wonderful. It was so thank you very much for your time in putting this together.
Yes, and Veronica, spread it around the doctor community where you are there in Kansas. This is going to be on the YouTube channel. They can get a quick review from a peer.
Absolutely. We're going to post this on our Facebook, and I wish that my husband was able to listen to this. He's on another webinar right now, but he definitely said take good notes and send it all my way so he can read it. So but definitely we, you know, that we send a lot of this stuff out to a lot of his peers, but there are so many people, or so many of the physicians say, well, we just don't have time for this. This is just, you know, we need to know more. We need to know more. And you have to read it.
I agree with you, Veronica. This is Rob, and my wife's father got this, and we're watching him, Rusty, just slowly fit into a lot of the stuff you were discussing. I mean, just, you know, poor memory, lack of focus, confusion at times. It's a really, and it happens, and it seems to happen quickly. When if it happens, it seems to go, and it goes quickly, and it worsens quickly. At least one single observation, at any rate. Go ahead.
No, and I thank you for your comment too. It's like, why we, quote unquote, are so busy that the conversations that I'm having like this aren't with the physicians, it's with the other clinicians like yourselves that are seeing people for QEEG, for neurofeedback, for counseling, for whatever, and you're getting that big history. And there's more and more numbers, and there's more time spent or wasted, spent on the having to enter everything in the electronic health record to get everything done. And they really do have, quote, less time. And that's true from at all levels of the healthcare system, where some estimates are 60 to 70% of a nursing shift is spent doing computer entry. And that's not what they were designed. If you don't ask, you won't find out. And I learned a lot going through this process. So I'm continue to, and then ask those questions. And how does this tie in with how are we exercising? How are we eating? What's our disconnection? What are we doing with EMF? And what's our sleeping? So
Those enhance our vulnerabilities, right?
yes, yeah, all about brain health.
Also, I'd like to refer people to the PBS series on Homeland Security. And I was really impressed with the frontline doctors and their open-mindedness and all that they revealed, because I too was just so frustrated with not getting anything that sounded like comprehensive science. And so in a strange way, it's possible through this crisis on the planet, which is worldwide, that even the medical industry could be, adopting a few changes along the way, because it was one of the more holistic sounding medical presentations I've ever heard in the PBS series.
Well, Rusty, you've done a little bit of traveling around the country, filling in as you do in different, hospitals or practices. It seems to me what's happening, and the reason maybe why some of these doctors aren't getting this is not as this information new, but how many people have the time to even look at any of this when they're struggling just to keep themselves practicing medicine and helping people? It seems like the whole medical community just appears to be overwhelmed.
Mm-hmm. And burnout is a now international issue. Burnout codes are in ICD-11, which has already been used in other countries. It's far better than ICD-10, but I don't know when we'll ever use ICD-11 here. But it's there because it's a I hate to say pandemic, it's a big issue in many professions, healthcare related. And then you throw all of this stuff into it where we're inside more, we're not outside, we're not getting sunlight, and people are exhausted. And when you're exhausted, your brain doesn't work. And so it's a pretty vicious cycle that you can help people when you're working with them with, addressing their lifestyle issues. And then when they can get neurofeedback, hello, you help it. Judy, do you have the name of that the Homeland Security, the PBS series?
Yeah, it's called Homeland Security Hearing on Early Outpatient Treatment for COVID-19. These are Senate hearings, and they're really seeking to get out of politics here and to just reveal the science. And in fact, I question if that's what led to the fact that now in New Mexico, they are using ivermectin in the hospitals, even though it took quite a while to get that through. And apparently that was used for several heads of state in different countries who have recovered from COVID. So it's Rusty, it's a several part series on PBS, and it's really worth the watch.
Okay, thank you.
Bree, can you post the link for us?
Yeah, post that.
Yeah, sure. I sent it around once, and I'm happy to send it again for sure. Yep.
Okay.
Great.
Veronica, didn't mean to cut you off.
Oh, no, you're fine. Yeah, so Dr. Sieberger's protocol treatment, which we've had so many more people coming to see him from everywhere, but it is ivermectin, it's indomethacin, it's omeprazole, 50,000 IUs of vitamin D, and then he also gets some specific labs. And if people are getting sick, their symptoms are less and they're recovering faster. So I think it'd be a really good thing for him to have a presentation on that, if you guys are interested in
Yes.
that.
Oh,
Yeah.
absolutely.
Have them
Absolutely.
contact me, Veronica. Just have them contact me. You've got my
Okay,
email.
do that. Yep.
And I'll set up a time with him. Have him give me some dates, a Monday night or a Wednesday or a Friday. We'll do it. Thank you so
Okay,
much.
sounds good. Yep.
In the meantime, if you could post what you just gave as that paragraph of chicken soup, the
Okay,
erythritol, et cetera.
I
I
agree.
can't write that fast.
no problem.
And I just got all the articles out on the listserv. So they should all be there. The ones that we were sharing back and forth, some of them to get to the listserv. So those are all out in the listserv now. And Rusty, are you going to share these slides?
Sure.
You want to send those to me? I'll post those as well. Thanks.
They're all just plagiarized from the work that I looked at, so nothing.
They're
We'll take your name off of it, and then we'll just no. All right.
Yeah,
And since we won't be meeting between now and New Year's, we have extra time to read
Yeah,
all
to
this.
do some reading, right?
okay.
Yeah, and we'll work as a group to put together a general presentation for everybody on how, with our technology, we can identify and support these issues and support people, within our own clinical setting.
Yeah, because if it's as big as it is, it's not just the hospital. They're coming out of the hospital. They're never making it to the hospital, and they're coming in for sleep and headaches and cognitive and memory and slowing and anxiety and all kinds of other things. And you're the ones that are going to be seeing them. So
Yep, we could flex our muscles as a field here.
Yeah. All right, folks. We should probably wrap this up. I know people have to get back to their schedules. Rusty, again, I don't know how to thank you other than to say thank you. and we appreciate so much your time. You're taking this science and putting it to a level that we can better understand it. Everybody, this is the last Lunch and Learn or Neuro at Night until Monday, January 4th. I've been sending out the schedule. At least for me, I'm sure the whole team here. I hope you have a relaxed, safe, enjoyable holiday season, and take care of yourselves.
Absolutely.
Echo that, absolutely.
Thank you, everyone, for an amazing year and for being there in these changing times. And Happy New Year, everyone.
Thank you, Bree. Thank you.
Thank you, Bree.
Yep, everybody. It's been wonderful having you all contributing this year, and I think next year will be even better. And we all need to keep supporting each other morally and showing up for these things so that we can move as a field forward, at least with our group, anyways, and help others. So thank you very much.
Absolutely. Absolutely. Bye, everybody. Thank you, Rusty.
see you.
See you
Bye-bye.
in 2022. One.
Hopefully one. Both true.
Bye, everybody.
Unconscious.
So long.
Maybe
Bye.
true.
Get some sleep.